Welcome back to the Stat Podcast, where we have conversations about the pre-PA life, PA school, and the PA you always dreamt of. Today we have a physician assistant working in gastroenterology and hepatology. Joshua Smith, aka Sheeran, aka the Gastroginger PA, has obtained his master's degree in physician assistant studies from Trevecca Nazarene University PA program in 2018. Initially, he started working as an internal medicine PA and a Nocturnist for 1 year, and then he transitioned on to a more specialized role in gastroenterology and hepatology. He has been practicing in that specialty for about 6 years now at Riverview Health Network in Indiana. He treats various conditions from upper GI to lower GI and sees patients anywhere from minor gastrointestinal conditions to severe inflammatory conditions like IBD. Expect to learn a lot about what a PA in gastroenterology does and what are some independent roles a PA can take in this field. As a PA student who has love and hate for GI, I learned a lot from this episode, and I hope you learn something as well. So, Could you tell us about what your role actually is, and then maybe share a little bit about how your role has changed over the years? Because I think you have quite a bit of experience after PA school, right? So maybe you can start off with that.
Yeah, so this is actually my third job after PA school. My first job was as a Nocturnist on the internal medicine team, and then transitioned to GI. I've done GI now for about 6 years, and I'm currently in my second GI role. So in a different network than what I was at. So I switched roles or networks in October. So I've been there for about 8-9 months now. So most of my time it's changed actually somewhat recently. I was doing pretty much all outpatient clinic, and then recently I've started doing some inpatient rounding as well. So a mixture of inpatient rounding, outpatient clinic. I also run a Fibroscan clinic or a fatty liver clinic. And so it's kind of a combination of those three things that make up my day-to-day.
Okay. So you said a little bit about being a Nocturnist. So I'm trying to just understand if that was your prior job, or is it like a contract type of?
So that was my first job out of PA school.
Okay.
I got hired with an internal medicine team on nights. So
Okay.
in that role I would do like 7 p.m. to 7 a.m. We would do 7 12-hour shifts in a row, and then we would be off for 14 days. But I was not built for nights, and so I realized pretty quickly that wasn't going to work. And then so I had the opportunity to switch over to GI and made that switch basically, right in 2020 when COVID was going on.
So how was the switch like from internal medicine to GI?
For me, it was actually pretty easy because I did both of them for a short period of time. I was doing part-time nights and then part-time GI within the same network. So I was considered like a full-time employee. And then my wife got pregnant, and I realized very quickly that it wasn't sustainable for me to do some nights, some days. And so made the switch to full-time GI. So I did part-time. I did both for probably, almost 6 months, and then made the switch to full-time GI.
Okay. All right. That's kind of exciting too, because as a lot of people just want to be a PA because of this opportunity to switch specialties. So I think that's pretty exciting. I have not negative distaste for GI. It's still not like, I'm not there yet with my interests, but maybe like talking to you and other people in GI, maybe I can change my mind around, because recently, the reason why I say this, because my recent likeness is also in OBGYN after my rotation. Not necessarily like the rotation site, but also learning about OBGYN was fun for me. And so that's why I say it. And prior to learning about OBGYN, I was like, I'm not going to like OBGYN. But like when I start learning it, ball starts rolling, and then you just start liking stuff. But with GI, what kind of conditions do you see on a day-to-day basis, on a regular schedule?
Yeah, so part of why I love GI is because I get to see so many different things, right? So if you think of most specialties, they focus on one organ, but the gastrointestinal system encompasses so many things. So you've got esophageal issues, stomach issues, small bowel, colon, liver, pancreas, gallbladder. So from the day to day, I can see patients with GERD, IBS, Crohn's disease, cirrhosis, chronic pancreatitis. So it's a lot of different things. It keeps my days very interesting, and I don't feel like I'm doing the same thing all the time, which I really appreciate.
Yeah, so I'm assuming you see a lot of different conditions, GI obviously, but how is your role in like inclusive towards like different populations? Do you see like just older folks, or do you see also like younger people, and like especially like with Crohn's and ulcerative colitis, like do you also manage conditions like that as GI? Because when I remember learning about IBD, we were told that you're not really going to manage that much of IBD, but how do you, what kind of populations do you see?
Yeah, so I manage pretty much anything and everything GI and hepatology related.
Hmm.
So my practice is just in adults, so we don't see anyone under the age of 18. But I have patients all the way from 18 up until, I mean, I think my oldest patient was probably like 97.
Okay.
And so there's no, for my role at the network that I'm at, there's no kind of red tape, meaning I can manage the mild disease but also severe disease. So I have patients on my schedule that have severe Crohn's disease, for example, or alcoholic cirrhosis, and so those patients are extremely complex. So I really like that too. I know I get the quote unquote easy things, like abdominal pain, but then I'm also managing, in the next patient encounter I go into, and it could be like an extremely complex patient with alcoholic cirrhosis and ascites and varices and hepatic encephalopathy, and it takes a lot more. So it's kind of nice that I have a mixture of those two things, both some of the easy and some of the more challenging.
Yeah, so what are some of those things, like skills especially, that you want to make future PAs aware of who want to work in GI specifically?
Yeah. So I think the biggest thing is communication, right?
Okay.
Because there's a lot of overlap, to be honest, in GI and psych. And so, a lot of people come to us with GI complaints and they've been written off, or people will say, my one of the soapboxes that I get on is IBS and how we as medical providers communicate IBS, because patients come to me and I'm having to spend the first half of our visit just kind of convincing them that IBS is real, that IBS exists, because most medical providers, I won't say most, but a lot of medical providers don't communicate it in a way that makes my job any easier. And so I think for people to learn how to communicate and to take the time to really explain things to patients and not to get frustrated when they don't understand, or they might push back, because I do encounter that a fair amount in my practice.
Can you share like specific communication tips that you think that has helped you in the past? Because I'm also trying to navigate that currently in clinical rotations on how to properly talk to patients, because it's such a learning curve.
Yeah.
Yeah.
I think one of the biggest things is being willing to listen, right? So before I kind of jump in and say like, oh, well, no, XYZ, or, go into my full blown, like, here are all of the medical facts, or, here is how I know XYZ. I listen to patients and I hear, their frustration. I hear their concerns. And especially if it's a patient that I feel like, we're going to have some issues, meaning that it could be a little bit tense, or they could, they're coming in with preconceived ideas. I'm not afraid to say very early on in a patient interaction, what is it that you're wanting out of this? What is it that you really want? And a lot of times people will say, I just want to be heard. I just want somebody to take me seriously. I want somebody to truly dig into what's going on and not just label it as, oh, it's just your anxiety, because that's something that I hear pretty frequently, unfortunately, in the world of GI.
Yeah, definitely. It must be really difficult to address IBS specifically, because I
Mhm.
remember it's kind of like a last line diagnosis. You can correct me
Right.
if I'm wrong, but yeah.
Well, so the term that most people use is a diagnosis of exclusion, right?
Yeah.
And that's true. There's nothing that's not false. I just don't love that term, diagnosis of exclusion, because the issue is that so many people stop there. So, they say to a patient, I think you have IBS, it's a diagnosis of exclusion. You don't have anything else, so you have IBS. There's not anything inherently false with what they're saying, but the way that they communicate that translates in a patient's brain to, oh, okay, so you just have no idea what's happening. You don't have an answer, and so you're just labeling it as IBS, right? But IBS is real. IBS is a real thing, and yes, part of the diagnostic criteria for IBS is that we have ruled out all of these other things. If you're skilled in GI, I mean, I've been doing this for 6 years. I can pretty much tell you within 5 minutes of meeting a patient with no tests or anything, whether or not they probably have IBS. You kind of get that, that they use the term gestalt or whatever. And I can kind of pick that out, but it's all about how we kind of communicate that to a patient. So instead of me saying, oh, it's a diagnosis of exclusion, you don't have Crohn's, you don't have celiac, you don't have ulcerative colitis, so that means you have IBS. The way that I kind of explain it to patients is, hey, IBS is a diagnosis of exclusion, yes. Basically what that means is, in the world of GI, so many symptoms overlap. So we have to rule out some of these other things because with IBS, there's not anything anatomically or pathologically wrong. We can do any test under the sun, and if you can have the world's worst case of IBS, and we can do a colonoscopy, we can do CT scan, we can do ultrasound, we can do blood work. They're all going to come back completely normal, right? But it's helping people to understand that those things coming back normal does not mean that it doesn't exist or that it's not real. So how I explain it to people is I say, hey, IBS is what we call a functional disease, meaning there's not anything anatomically or pathologically wrong, but rather it's just not functioning the way that it should. And so I think if you take the time to truly explain that to people and help them understand, that, okay, this is what this means, they don't feel like they're being discarded. They don't feel like they're not being taken seriously. And so I will always communicate with them like, hey, I am going to do everything I can to make sure that we know exactly what's going on. But I'm also not afraid to tell them, I'll say, hey, I'm going to do everything I can, but I also need you to be open to the fact that if all of these things come back negative and I say to you, hey, in my personal professional opinion, this is IBS, this is what's going on, I need you to be willing to hear that or open to hearing that, because so often, we live in a society where they're like, oh, but the underlying cause, right? They want to know what's like the root issue. And with IBS, there isn't one. It's just that's kind of what's going on. And if I can get people to understand that and accept that, then we can move past that to, okay, how am I going to make you feel better?
Yeah, I think that's a very critical advice, because communication is something that it should be part of PA education. I think it takes a lot of effort for future PAs, like including myself, to learn how to communicate. But I anticipate that one of the things that could go wrong in that scenario is when a clinician doesn't fully understand the pathology. So in that scenario, what would you say, or what kind of advice do you have to, let's say a new grad PA working in GI who does not understand the pathology quite well, and they have to communicate this exact thing?
Yeah. So at the root of what I tell people IBS is gut hypersensitivity. Okay, so we know that the brain and the gut are extremely connected. And this is kind of how I phrase it to patients. I say, we know that the brain and the gut are extremely connected. It's the reason that you get the butterflies when you go on a first date, or you might feel like you're going to puke if you have to public speak, or you're about to get on an airplane and all of a sudden you're running to the bathroom, right? We know the brain and the gut are connected. In patients that have IBS, that connection just goes a little haywire. And those nerves that connect the brain and the gut become hypersensitive. So things that shouldn't typically in a normal situation cause those nerves to fire, in patients that have IBS, that threshold is much lower. And so those nerves are firing at things, at stimuli that they shouldn't, quote unquote, shouldn't in a normal situation. I think that kind of helps people to wrap their brain around it. We all understand that idea of being overly sensitive, right? And so it's basically at the root of it, that's what IBS is that your gut is just extremely sensitive to things that the rest of the population, they don't struggle with.
Yeah. Do you have any oh, go ahead.
I was just going to say, I think part of with PAs specifically is I think we are very prone to experiencing imposter syndrome. And so we, especially with these hard conversations, I think we already kind of have this thing in the back of our minds of okay, I can do this. And then when a patient kind of pushes back on something, then it's you almost get this freak out moment of oh, wait, no, I know what I'm doing. You know what I mean? You kind of get defensive, and then patients get defensive, and then you get defensive, and then you don't go anywhere. And so I think one of the best things that new grads can learn is that it's okay to not know everything, right? Mm-hmm. And it's okay to be honest. If a patient asks a specific question and says, hey, and you don't know, you know what, I actually don't really know that. Let me look into that and I'll get back to you or whatever. But I think so many of those hard conversations happen because we already are fighting our own demons, right? We're already fighting our own feeling of, okay, am I adequate? Can I do this? And so when patients kind of push back, we almost kind of freak out. And I think that that's what makes those types of conversations more difficult for people to have.
I think that's also a good advice. But do you have any other medical skills that people or future PA should work on if they really want to be better at managing GI conditions?
I think one of the biggest skills is just developing a differential, right? Because again,
Yes.
especially in GI, so many of the diseases that we have the exact same symptoms, right? So a patient comes in with abdominal pain, diarrhea, and bloating, right? That could be IBS. That could be Crohn's disease. That could be, ulcerative colitis. That could be small intestinal bacterial overgrowth or SIBO. That could be chronic pancreatitis or exocrine pancreatic insufficiency, right? So it's, I think, trying to keep your mind open and kind of take it piece by piece. So these are all of the possibilities. What can I rule out with this specific test, or what can I rule out with this specific thing? And then kind of work through those piece by piece.
Yeah, I think that's also a wonderful take because it wasn't until my quarter four of PA school where my advisor told me, like, if you're struggling with OSCE, which I was, I remember GI was our quarter four, and she told me, like, I should write 3 differentials as soon as I see the chief complaint. And I think I took that throughout my rest of my didactic and clinical rotation. And I think that helped me out a lot, honestly. And this also further reinforced the idea of the importance of differentials, because it could be GI related or it could be non-GI related sometimes. And I feel like for me, I'm just assuming that I'll be in primary care first. Like, if I understand this, I won't miss non-GI stuff plus GI stuff. So thanks for sharing that too. Yeah.
Yeah.
So what are did you want to add something there? Oh, okay. I was going to ask, like, I know communication challenges could happen in scenarios like this, but what are some other challenges that personally you have faced? It could be professional, it could be personal that you want to share, but what are some of the challenges that you have faced in your career so far?
Yeah. I mean, I think one of the things that, is getting less and less is people not understanding the role of PAs and what we do and what we don't do. And I think that to some degree can be a bit of a challenge, helping people to understand that, because you're always going to have those patients that you walk in the room and they're like, oh, what are you? And not kind of letting that get to you, and being confident, and you'll always get the patient, or, that's like, well, when are you going back to school? And I'm like, I'm not. I am where I am, and I am where I want to be, and I'm perfectly happy and perfectly content with this, right? And so you kind of have to, kind of get over that to some degree as well. GI specific challenges, I would say that, there are certain populations that we deal with that are a little bit more challenging, and even within the same disease. I've taken a huge role with a lot of liver disease in my current role. And, so cirrhosis, I could see one patient who has MASH cirrhosis or metabolic dysfunction, historically we called it fatty liver disease or NASH, but cirrhosis from that versus a patient that has cirrhosis who's actively drinking alcohol. Right. And so, you're always going to encounter patients that they're not doing the things that you think that they should do, or they're actively making decisions that are making their diseases harder to treat. And so I think one of the challenges is kind of being able to overcome that and still give, both of those patients the same level of care, both of those patients the same level of compassion, even though, one is a little old grandma who, kind of got this out of unlucky genetics versus somebody who's been actively drinking alcohol and just can't stop. It can be really easy to look at those and say, okay, this one I like, and this one is really, is much more challenging. But at the end of the day, like, your job, the calling that you have is to take care of both of those people. And so it can be kind of challenging to wrap your brain around that, but it's just a part of what we do.
And so you said you manage NASH and also alcoholic liver disease and cirrhosis. Going back to communication, how do you communicate? How do you counsel patients on you have to stop drinking or you have to lose weight? Like how do you approach those conversations too?
Yeah. So I'm a little bit more delicate with the conversations about weight, right?
Yeah.
I'm a little bit more I'm straightforward, but I am a little bit more kind of delicate in how I kind of bring those things up, because it's important for them to know that, right? It's important for them to know, but I think you're going to be very hard pressed to find somebody who doesn't already know that that their weight is a problem and that hasn't already tried certain things to kind of overcome that, right? So a little bit more of a gentle approach. With my patients that have alcoholic cirrhosis or might not even have cirrhosis but are still drinking quite heavily, I'm not afraid, and this is just my kind of personality. I'll say to them, hey, I prefer not to beat around the bush. Is that okay? And then they'll say, yeah. And I say, okay. So the amount of alcohol that you're drinking is extremely dangerous. And if you continue to drink this amount, or if it's a cirrhotic, if you continue to drink alcohol to any capacity, it is going to be very challenging for me to help you. And I will do everything that I can. But at the end of the day, you need to know that this is life or death. And the damage that you're doing is significant and is severe. And I think sometimes people really respond well to that. They respond well to somebody kind of, I don't know if calling them out is the right term, but basically saying like, hey, I'm going there, we're going to go there. And if you keep doing this, my hands are going to be tied. I think that they respond well to that for the most part.
What do you think of using the same approach as someone who is a PA student in clinical rotations? Because like sometimes during patient education, when I'm in a room alone, I tend to have some barriers of things that I can say and can't say. So do you recommend using your approaches, whether it's communicating about IBS or like communicating about alcoholic fatty liver disease and weight loss? How do you recommend doing that as a PA, like a PA student?
I think to a certain degree, right? I think PA school and on those clinical rotations is a great opportunity for you to kind of dip your toe in the water and test it a little bit, but also recognizing that at the end of the day, you are a student and you are not the provider who's responsible. And,
Exactly.
the things that you do and say, eventually in a couple of weeks, you're going to be gone, right? You'll probably never see that patient again. But your preceptor is going to have to manage that person's condition potentially for forever, right? And so
Yeah.
being very careful to not damage that relationship by what you're saying. And so I think it's best when, you take the first couple of weeks of your rotation to listen to how your preceptor communicates things. And I remember when I was on rotations, there would be things that, I would want to say that I know my provider that I was with wouldn't say, or vice versa, things that they would say that I'm like, did you just say that out loud to this person? But I think you take that time to kind of get to know them and how they communicate things and the preferences that they have. And then you can kind of work within that framework. If you know that your preceptor is pretty like, okay, hey, here's where we are. This is what you have to do sort of thing. You can kind of be a little bit more aggressive. But if your preceptor isn't kind of like that, you can have those conversations with your preceptor outside of that of, hey, how would you communicate this to them that, that their weight or that they're drinking or they're smoking or whatever bad habit we all encounter is really affecting them? Because the longer you're practicing, the more and the deeper the relationship between you and that specific patient gets, the more you know what you can and can't say. I have patients that I know they're not going to respond well if I come in like, full force ahead and I'm just like, hey, you've got a XYZ. But then on the other side, I have patients that they'll call me out. They're like, why are you beating around the bush? Just say it like it is. Say it how it is. What are you trying to say? But as a student, you don't have that relationship yet. So it's a great opportunity for you to kind of develop your own tactics or your own kind of arsenal of like, okay, how do I want to communicate XYZ, but doing that in the framework of, whatever your preceptor's doing.
What are some big picture things when you think of GI and GI conditions and that are related to how am I say this? But what are some big picture things in GI that future PA should be aware of? Like one of the things you said is how to communicate with these types of patients, whether it's alcohol use, weight loss, IBS. What are some even like colorectal cancer? Like what are some big picture things in medicine in GI that just we should be aware of, and just some pieces of advice in that region?
Yeah. So some that come to mind, you mentioned colorectal cancer. Unfortunately, we're seeing that at a huge
Earlier.
increase in younger patients, which is terrifying.
Yeah.
So as far as that goes, I would say to take patient symptoms seriously in GI, especially rectal bleeding, right? So I think a lot of providers will, patients will say like, oh, I have a little bit of blood when I wipe, or, oh, there's just a little bit of blood occasionally. And they'll say like, oh, okay, it was probably hemorrhoids, whatever. In my line of work, we take rectal bleeding very seriously. So if you come to my office and you're like, I have a little bit of blood every once in a while, again, I can pretty much know like, it's probably hemorrhoids, but I'm not going to take that chance. Like you're going to get a colonoscopy because I'm not going to be the one that kind of misses that. Specific things like rectal bleeding or unintentional weight loss, like if somebody comes and they say I'm losing weight and I don't know why, those are things that you don't ignore those.
Mm-hmm.
Kind of more, I would say more general, which is, it's funny, but I have this conversation so often, is to ask patients seriously about their bowel movements,
Right.
because so many of the things that I manage, I can't even begin to tell you how many patients come into me and they've been into the ER 3 times with abdominal pain, and they get CT scans and the CT scan is read as completely normal. And I look at the scan and within 30 seconds, I'm like, well, you're like super constipated and that's why you have pain, right? So not
Oh,
kind of digging into those things and saying like, okay, hey, like maybe this is it, right? Because patients come in and they're like, oh, I'm not constipated, I go every day. I'm like, just because you go every day doesn't mean you're not constipated, right?
yeah.
You can still have a crazy amount of stool in there and that could still be causing your symptoms. And I tell people like the GI system is one giant tube. So everything that happens down below is going to affect everything that's happening up top. So if a patient comes in and they all of a sudden have worse reflux, are you pooping? No? Okay. Well, probably if we can get those things, if we can get you going, then it'll take less pressure off of your stomach and your reflux will probably get better, right?
Yeah.
I would say that it's something that a lot of people don't like asking about, and it's something that patients don't like answering even more. But it is, in my line of work, it's definitely something that we have to dig into because it causes so many things: bloating, abdominal pain, nausea, heartburn. I mean, they can all be constipation related, and we get that taken under we get that controlled, and those other things just like disappear.
Yeah, those are some also very crucial. But like with the hemorrhoids, I shouldn't laugh. I was like laughing because it's gonna be hemorrhoids on the question in PA school
Right.
on your
Right.
rotation exam. But I don't think you can miss that in real life because I feel like at students, like you have these so many exams week after week, and then you have end of rotation exams, and you're just fixed in that mindset. Okay, if this patient bleeds, if there's bright blood bleeding, it's probably gonna be hemorrhoids.
Hmm.
But like
Right.
in the real world scenario, obviously it may not be. And
Right.
then again with the second example you shared, it is important too in that case. But you mentioned your job requires you to do some fibroscans, and I saw a TikTok you made about what it is. And so does it basically scan your liver and tells us like how cirrhotic your liver is? But you can
So
correct me if I'm wrong. Yeah.
yeah, so a Fibroscan tells us it's a special type of ultrasound of the liver, and it tells us two different
Hmm.
things. It tells us how much fat you have in your liver. So everybody has fat in the liver, but it helps us to
Okay.
quantify how much there is. And then it
Hmm.
helps us to determine if you have any stiffness or fibrosis. So I
Okay.
tell people that, a CT scan or a normal ultrasound is basically like I'm using a camera to take a picture of your liver, whereas a Fibroscan is more like I'm poking it, right? So I'm poking your liver to see how much fat there is and how stiff it is, because fibrosis turns into cirrhosis. And so it helps us to kind of determine where somebody is on that spectrum. They have no fibrosis, they've got a really healthy liver, they've got a little bit more, and then, full blown cirrhosis.
What? So is that something that you're the only one who does it at the site?
Yeah, so I'm the only one that does them at my clinic. We are trying to, get some other people trained to do them, but as of right now, I'm the person that's trained to perform the scan and then also interpret the scan. So I do all of the scans for our practice.
What are some things that I don't even know if it's gonna be, like essential at this point, but do you think like fibro scans are gonna be more widely used for people just starting out in GI right after school? Or is it something that's evolving and
Yeah, it's kind of
getting
hard to
really
say. I mean, they've been around for a while, but it is a special type of machine. So it's not just a
okay.
normal ultrasound machine, and so not every GI practice has them. And so at my clinic, I actually scan for, I think, probably two or three different GI practices in our area. They send their patients to us for me to do the scan, and then they go back to them to kind of manage it. So everywhere's a little bit different, but I hope that it becomes more commonplace because it truly is an awesome tool in helping people to get a better idea of kind of where they're at from a liver standpoint, and ultimately helps to prevent us from having to do so many liver biopsies.
Okay, got it. Yeah. Do you have any other tools that you want to share or any other advancements in the field of GI that we should be aware of?
So from a PA standpoint, I would say that's kind of the majority of it. I know that some PAs do like point of care ultrasounds, looking at, potentially like gallstones, or, determining if they have like ascites or something like that. As far as kind of procedures go, obviously the doctors, the physicians that I work with, they do upper endoscopies, colonoscopies. Some physicians will do endoscopic ultrasounds or ERCPs, those sorts of things. But from a procedure standpoint, in my old role, kind of what I didn't do Fibroscans at my old job, but I would do some G tube, like I would pull G tubes, or I would exchange them if like the tube fell out. I don't really do that in my current role now, but those are kind of the two, I guess, procedure based things that I've done in GI is managing some G tube or feeding tube stuff, and then now doing the Fibroscans.
Okay, great. And do you have any last bit of advice for future PAs who are studying GI, like going through their rotations or didactic year? I know the surgery end of rotation exam is like 17% GI now. It was 50% back, but they just changed it to 17%, but it's still a high amount. And then the PANS is, I believe, 8 or 9%. It's up there with cardiology and respiratory. So do you have any sort of advice for those people, especially myself, who is like studying all these topics?
Yeah. I mean, I think really the thing about it is that you would be hard pressed to find a specialty where GI isn't going to play a role, right?
Oh, yeah.
And so, if you're going into primary care, if you're going into urgent care or ER, surgery, even like some cardiology stuff, right? Like it can play a role there, if they've got like fluid overload, things like that. I think for everyone to just kind of take it seriously, because I guarantee that regardless of what specialty you go into, you're going to come in contact with a patient that has some sort of GI complaint, right? Everybody poops, right? So that's just the reality. We, as a specialty, like, not everyone needs a cardiologist, not everyone needs a nephrologist, those sorts of things, but everybody poops, right? So
Yeah,
I think just kind of taking it seriously. Yeah, taking it seriously and recognizing that, to at least some level, you should feel comfortable with different GI diseases, and things like that.
Okay. Well, this was great. I learned a lot from how to communicate tough issues with your patients, but also like to take GI more seriously. And I kind of like what you do with the fibro scanning and also managing different GI conditions. I think that would excite me too if I had to take a job in GI. So thanks for talking, and thanks for talking to our audience on TikTok. I hope all of those, your followers combined and mine, I'll say 10,000 people. I hope even like 100 people watch this. It could benefit them.
Yeah, absolutely. Well, thanks so much for having me. I appreciate it. Yeah,
Definitely.
Of course. Thank you.
It was a nice time.